and thanks for joining us again for one of these fascinating interviews with our well-esteemed consultants based in the UK. And today, I'm delighted to say we're joined by highly esteemed urologist, London-based and also based in Windsor and Reading, Mr. Philip Charlesworth, to talk all about the diagnosis and prognosis of prostate cancer. Thank you so much, Mr. Charlesworth, for joining us, and thank you for your time this afternoon.
No, I'm very grateful. Thank you for inviting me along. Yeah, I'm Philip Charlesworth. I'm based in Berkshire and in London. And kind of my main area of specialty, although I do urology, but my specialist interest is in pelvic cancers, particularly prostate cancer and bladder cancer, with then a specialist interest in the diagnosis and the surgical management of that, particularly in robotics. And I've done an awful lot of robotic surgery over the last 10 years or so, and pioneered a number of new techniques in that area. But it's something I'm very passionate about. And yeah, I'm very happy to answer questions and to help in any way I can.
Fantastic, Mr. Charlesworth. Excellent stuff. So, if you'd like to maybe head into the questions. And the first one, in terms of diagnosis, and more and more people getting diagnosed with prostate cancer, or is it decreasing in the last number of years, do you see?
So the with prostate cancer, there are 1 in 8 men in the UK that will get diagnosed with prostate cancer in their lifetime. And that number increases to 1 in 4 men if you have risk factors. So family history, if your ethnicity, or if you have a family history of breast cancer as well. So and the diagnosis of prostate cancer is kind of slightly shifting landscape, because getting low grade, or age related very small low grade cancer in the prostate is very common, and traditionally it hasn't been a huge concern about prostate cancer diagnosis, and it's got this reputation that prostate cancer is something you die with, not from. And in large parts that is true, but as men are getting older, and not dying of other processes, then you look at across the UK and across the world, is that actually the death rate from prostate cancer is increasing. And I think it was 2015, the death rate in the UK from prostate cancer overtook breast cancer for the first time. So the UK curves for looking at how many ladies are dying of breast cancer is going down, but at the same time, the amount of men that are dying from prostate cancer is going up. So as a backdrop, I feel, and I think a lot of my other urological colleagues feel that deal with prostate cancer, that there's more that we can do, and more that we can get better at understanding prostate cancer and diagnosing prostate cancer, and differentiating between men that have low-grade disease, which we can keep an eye on, and wouldn't necessarily deem as clinically significant disease, and the men with more significant disease and higher risk disease, and catching that at a point where we can offer curative treatment.
Absolutely, doctor. I think definitely the outlook is definitely looking more positive, I suppose, with the current treatments, modernized treatments. And what are the most effective ways then that men can avoid getting diagnosed with prostate cancer? What would be your main recommendations in terms of prevention?
So prevention is, people have looked at this for many years, and the jury's still out if there's anything really robust that men can definitely do to avoid ever getting prostate cancer. So there's a degree of genetic predisposition. There's a degree of bad luck. If you're going to get it, you're going to get it. There is some evidence that eating well and exercising well have preventative anti-cancer effects of all cancers, but also including prostate cancer. So I suggest to my patients that they eat a very colourful diet, very bright, lots of antioxidants in it. And exercise has to be high intensity, breathless exercise, ideally for at least 20 minutes, 3 times a week. And that's, it's not going to be an absolute prevention about getting any cancer. But I think if you're doing those things, you are doing the best you can to protect your body from all kinds of different diseases, including prostate cancer.
Fantastic. So your recommendation there, Mr. Charlesworth, would be 3 days a week, 20 minutes, or would you even would that be a minimum 3 days a week in
Yeah.
terms of, okay.
Yeah, I mean, I think it's not rocket science to say if you look after your body, you eat well, and you do some exercise, you're going to do well. That everyone kind of knows that but there is some evidence to back that up specifically to prostate cancer. But I think, if you look after your body and you care about what you put in it and you exercise it regularly, then it's going to last longer than if you don't do those things.
Absolutely, Mr. Charlesworth. Well said, for sure. And well, leading nicely on to our question number 3 then. And what typically happens after a patient is diagnosed with prostate cancer?
So, the diagnosis of prostate cancer has changed a lot in my career, and that's mainly due to the advent of using MRI scans as an upfront tool to look at prostate cancer. So, the old pathway used to have a PSA blood test, and if that was elevated, then you would come up and have a biopsy, a rectal biopsy into your prostate to try and diagnose your prostate cancer. And that was fraught with difficulties and not particularly pleasant for the men going through it, and also dangerous because when you're biopsying through the rectum, we used to have to give people lots of antibiotics, but there's still quite a high risk of getting infection. Plus, that type of biopsy wasn't always that accurate. So you could actually misdiagnose and say to men that they didn't have cancer when they did. So things have changed a lot over the last 5 to 10 years, that we now do MRI scans. If anyone's got a slightly raised PSA, so that everyone starts with a PSA blood test, but if you've got a slightly raised PSA, you come and have an MRI scan. If you've got a high quality MRI scan, in the vast majority of the time, it can differentiate between normal prostate or benignly enlarged prostate tissue and cancerous tissue. And then if we need a biopsy, we can do a targeted biopsy, which we often do under local anesthetic, and we do it transperineally, so through the skin, so it's nice and clean, and the risks are much lower. And we can use various different software and technology nowadays to aid us in how we target and how we aim at the target lesion within the prostate. So that is much safer. We have to do it on a lot less men because the MRI scans filter out the men that don't have a lesion and don't look like they have prostate cancer. But it significantly improves our yield rates. So we're picking up men with more significant disease. And the other aspect of MRI scans is it tends to, not always, but it tends to ignore almost or not see quite as well the lower grade cancers and the ones we don't really want to find anyway, the microscopic disease that's really low grade that you're going to drift along and have for many decades and it's not going to be dangerous to you. So where we're doing less biopsies, we're finding less low risk disease and stuff we don't want to find. So proportionally, we're finding much higher, a higher proportion of significant disease. So the pathways got a lot better. Now, sorry, your question was what happens typically at diagnosis. So yeah, you have a blood test. If it's elevated, you have an MRI scan. If it's normal, it stops at that point. But if it's abnormal, you have a biopsy. And once you have the biopsy, you come and see someone like myself, or maybe I'm doing the biopsy or I'm doing the MRI scan. And I sit down, we have a chat about what type of prostate cancer it is. We marry that up with what your MRI scan is. We will probably do some other scans to check the rest of the body for any evidence of spread. And we have a chat about options and treatment options.
Fantastic, Mr. Charlesworth. Very thorough answer there. And you just touched on, I suppose, the accuracy then. How accurate would the current diagnosis method be for prostate cancer?
So, yeah, far better. I mean, the original pathway that I was talking about having a raised PSA and then going straight for a transrectal biopsy is about 60% accurate, which doesn't sound high enough in my books. The modern way of doing it is up to 98 to 99% accurate at hitting the prostate cancer. So yeah, nothing's 100%, but yeah, I'd take 98% over 60% every day of the week with regards to accuracy of a cancer test. So yeah, very accurate. Once you got the biopsy, and you can then cross correlate that back to the blood test and the level of the blood test and to the MRI scan, and as well as any further imaging. So you get a really good, clear understanding of how much disease there is, where the disease is, and where there's any evidence of spread, and using predictive models about what the likelihood of spread is over the next few years or lifetime, to assess whether treatment at this point is necessary, or that it's safe to keep an eye on it for a period of time before treatment, if at all is necessary.
Absolutely, doctor. And I suppose, well, going a little bit into a new direction now. I suppose Movember coming up, of course, in just over a month. And in terms of awareness, that is a fantastic initiative, fantastic month in terms of raising awareness for prostate cancer. But do you feel as though enough is being done in terms of raising awareness, and what more can be done?
No, it's with raising awareness, it's the recent sad death of Bill Turnbull is I've seen a flood of patients that have come in my clinic in the last few weeks. It's amazing when awareness is raised about the dangers of prostate cancer, and men who should be alive if the cancer was caught early enough of passing away from prostate cancer. It certainly concentrates the mind about getting checked. Now, there are symptoms of prostates, of having an enlarged prostate or having prostate problems, which everyone feels is, and understands the urinary tract changing and the flow decreasing, or you're getting up at night, or you're getting a bit more urgent. Now, the vast majority of the time, those changes are due to an enlargement of the prostate, which is just a benign process which goes on as we all get older. But it can rarely be a sign of there being cancer in the prostate and changing. But actually, what's much more common, and the prostate cancer we tend to find much more regularly, are men that have just gone and got a PSA blood test. And we saw this over the COVID pandemic, where access into getting blood tests was not as easy through primary care and through GPs. That the amount of prostate cancer that we were diagnosing went down significantly. So, as far as raising awareness, then there's one thing is raising the awareness of prostate cancer is a significant disease, and there will be men that die unnecessarily in the UK and around the world because they are not diagnosed at an early enough stage. And the best way to find out about that is to understand what your PSA is. And historically, there has been a reluctance for men to get their PSA checked because of a fear of going and having a transrectal biopsy, or going down a path of having unpleasant tests to diagnose a disease which didn't feel, or some doctors felt didn't need to be treated. And as I said a few minutes ago, the pathway has changed a lot, and the accuracy has changed a lot, and the detection of what we call clinically significant and more aggressive disease has gone up proportionally very, very high now, and it's very rare now for us to treat, even if we find it, it's very rare for us to treat low-grade disease. So raising awareness is really important for men to understand that prostate cancer is a significant disease, and the best way to start that journey and to shield yourself from being an unlucky man that presents too late with very advanced cancer is to know what your PSA is and get your PSA checked. And then if that PSA is slightly elevated, is to have an MRI scan, which will filter out a lot of these men. Now, on a higher level, and on a government, on an NHS, and on a UK health basis, now that's falling short of a national screening program. There are national screening programs for lots of cancers, including breast cancer. There is not a national screening program for prostate cancer. Now, that falls above my pay grade to advise and to be making decisions on that on a national basis. But my advice is, and the advice of esteemed bodies like Prostate Cancer UK, and my what I go and speak to my GP colleagues in primary care, is that I think all men from the age of 50 should have a PSA blood test. And if it's normal, it's great. You just have an annual PSA. That's fine. That can be formed as a part of a health check by having your cholesterol checked or your blood pressure checked or whatever. You can just have a PSA checked. But if it's elevated, then we can investigate that by doing an MRI scan. And that age probably needs to be a bit less if you have risk factors. And we should be looking at men with risk factors of family history of prostate cancer, a family history of breast cancer, or black ethnicity from the age of 45. And that's my opinion. As I said, there's no national agreed standard on that.
Fantastic, Mr. Charlesworth. Very important information there. And you touched on the age, mainly 50 years of age, a little bit lower in terms of men with certain risk factors. And then how often then would you suggest that men get their PSA checked?
If it's normal, an annual PSA is more than sufficient.
Perfect. Okay, Mr. Charlesworth, on to our next question then. And you did touch on it briefly in the opening few minutes about the prognosis. And then how long, on average, can men typically live for after being diagnosed with prostate cancer?
So we could probably break that down into men with low risk disease, with small volume, low risk disease. The current UK NHS agreed practice is that we don't, on the whole, treat low grade disease. So the prognosis of low grade disease is that you probably will avoid any treatment in the course of your life, and you'll die of whatever other natural causes you are destined to die from in later life, and you will avoid treatment. Although there'll be a few men with low risk disease that will progress and need treatment. If you have localized prostate cancer, as in the cancer is still contained within the prostate, and it is deemed to be higher risk enough to be a threat to your life within the next few years, and you're well enough to go through treatment, which obviously most men would be, but maybe if you're very elderly or very poorly, you might not be. But if you've got localized disease, then radical treatment should cure you of that. The idea is that it is with curative intent. So if you remove someone's prostate surgically, if you irradiate that prostate with radiotherapy, then the idea of that is that you're killing all of the cancer cells within the prostate, and then you are cured. So that's the intent. And now there will be some people that don't quite fit that mold and it comes back or need other treatments, et cetera, et cetera. But that's the general broad brushstrokes of localized treatment. When you have locally advanced or metastatic cancer, so it's already spread throughout the body, then you're not necessarily talking about cure of that, although there have been a few reported cases possibly of men that have been cured with metastases. But I think broadly, if you've got widespread metastatic disease, you're talking about control of that disease process and that disease as much as you can for as long as you can. And the good news with prostate cancer is that's largely very successful, because prostate cancer is very sensitive to hormone treatment, and certain derivatives of testosterone, where if you starve the body of that testosterone or that derivative of testosterone, then the cancer cells shut down, and they can shut down for many years, sometimes many decades. So there is very effective treatments. There are novel treatments that are coming out all the time, and some very exciting new developments about different hormone manipulations, different chemotherapy agents, different targeted radiotherapy agents which can be injected. There's some very, very exciting things that are coming out for that disease. And new things will come out in the next 10 years to 20 years as well. So it is a disease that's got lots of different treatment options, but it still is best if you can find the disease when it's localized and you can just treat it locally. And then you're talking about getting rid of all of the cancer. You're not talking about controlling it.
Absolutely, doctor. And I'm glad you touched on the treatment there. Leads us nicely into the next question then. Are all treatment options for prostate cancer suitable to all patients, or do you see some patients reacting differently in terms of side effects?
Yeah, absolutely. There are a number of different types of treatment for prostate cancer, as I said, ranging from active surveillance, which is just a close surveillance of prostate cancer, through to focal treatment, where just a small area of the prostate is treated, through to surgical removal of the prostate, which is one of the things I do a lot of, which is all done with very expensive robots and by high precision ways that we can try to minimize the side effects associated with surgery, mainly continence and preservation of sexual function, which are getting better and better and better. And then through to radiotherapy, which is by either shining beams of radiotherapy through the patient targeted at the prostate, or inserting seeds of radiotherapy. And there's lots of different developments in radiotherapy machines and different targeting approaches of radiotherapy machines that can be used to again decrease the collateral damage of to the prostate. So killing all the cancer cells, minimizing any risk to anything else. And it's often the side effect profiles that will mean which treatment modality is most suitable for each patient. And that's a conversation that a urologist and an oncologist will have with the patient on diagnosis of the cancer. So once a patient is diagnosed with cancer, then there is an MDT process, which means that all the regional experts in prostate cancer will sit down, go through the MRI scan, the biopsies, the PSA, the staging scans, and decide which group of treatments would be suitable for that patient and which ones wouldn't. And then there's a conversation by the urologist and the oncologist with the patient to say, look, these 2, 3, 4 options are available to you. These are the pros and cons of each of them. And then it's up to the patient to choose which is the kind of least worst, is the way I tend to say it, is that which is if you were going to be really unlucky and get some side effects, which of those side effects would you be able to cope with best? And so we have a conversation with patients about choosing the best type of treatment, the best bespoke treatment for them, and then and giving them lots of different options, get to speak to lots of different people, get them involved with other patients and support groups if need be, get them to meet physiotherapists and erectile recovery specialists, which we do. We sit down in groups. We go through prostate schools and educational sessions with them from a surgical point of view. So there's lots of huge amounts of information we give these men to help them make a decision. And once they made a decision, then we get on and action their treatment as soon as we can.
Fantastic, Mr. Charlesworth. And then our last question then, I suppose, well, of course, it is always better to be diagnosed with any illness at the earliest stage possible. But let's say if somebody is diagnosed at a late stage, quite an advanced stage of prostate cancer, what is the outlook for them? Is it curable, or does it depend on the individual?
Yeah, it depends on the extent of the disease and how advanced it is. But prostate cancer does respond, even when it's caught very late. It does respond very well to treatments. As I said, it's rare, and it's probably false optimism to say that metastatic prostate cancer is curable. It's often not, but it can be suppressed for long periods of time with the treatments that are available nowadays. So, and there's the story that a lot of people will remember is al-Megrahi, who was the Libyan bomber for Lockerbie, and he was imprisoned in Scotland, and he had prostate cancer, and he got released on compassionate grounds because he was deemed to only have a month or so to live from prostate cancer. He then went back to Libya, where they put him on one of the novel agents, which wasn't yet approved in the UK, for prostate cancer, which is now approved on the NHS and is widely used. But he put on that and he lived for another 2 years on these novel treatments. So it's not a particularly nice story for considering what he was in prison for in the first place. But from a prostate cancer point of view, I say that story quite a lot to chaps that are present with metastatic disease, because not only are there the treatments that we have at the moment, and there are these new treatments that have come out in the last 5 years, which are proving really effective, but we also don't know what's coming around the corner in the next 5 years or 10 years with regards to newer treatments that will then become available. So there's a huge amount of work that's going on in the background by clinicians and researchers and people that are far more intelligent than myself about coming up with these new ways to treat metastatic disease. And so it's something that needs treatment, needs management, but it is something that can be controlled in a lot of cases.
Fantastic. Mr. Philip Charlesworth, a fantastic overview on prostate cancer, very reassuring and informative for all patients. And well, any viewer or a listener who might be more interested in finding out more about prostate cancer or Mr. Philip Charlesworth, you can head on over to his Top Doctors profile at www.topdoctors.co.uk. And Mr. Charlesworth, many thanks for joining us this afternoon. It's been a pleasure.
Not at all. Thanks, Connor.